السلام عليكم. السلام عليكم يا جماعة. الصوت واضح؟ رجاء بس غلق المايكات أول بس ما نخش ونعمل جويننج للميتنج كده يا جماعة. بإذن الله نبدأ. Dear colleagues, it is a great pleasure for your attendance to our free Patient Safety Awareness Conference 2021 that hosted by CPPS-tricks platform. This free conference is scheduled to be held on March 12 to 21, 2021 through Zoom video conferencing. This event is a comprehensive learning experience that assists healthcare professionals to learn about how to create a world where patients and their family are free from harm. Also, we need to understand the full impact of patient safety problems and look behind institutional healthcare or fragmented care, the full care continuum. Also, we need to create a world where, as a caregiver, be healthy or be safe to save your patient. This conference is aimed to raise awareness about patient safety among the healthcare providers, and also to learn how to encourage the patient and their care as a patient safety strategy to transfer risk to their own through improving their health literacy by fostering the partnership between the healthcare facilities and their patient and the family. Also by improving communication between the healthcare facilities, our provider and their patient and the family. And we are today, we learn or we hear to our panelists or our expert to how to the rule effective communication on patient safety. Also, we learn this conference is aimed to improve the self-management of the patient, to improve the patient outcomes and make their condition to be under control. In CPPS-tricks platform, we and our partners are excited about this activity, which is designed as a series of expert-led webinars to be one of the scientific knowledge sharing event and a real opportunity to learn and network. So, welcome to the third day of our free online event that conduct in celebration of Patient Safety Awareness Week. Our success based on our expert who gave us the opportunity to conduct this online event, which aim to play a role in culture transformation toward medical care free from harm with provision of a reliable care, meet patient need and the need in our community. Today, we will hear to one of our expert panelists in Middle East who will share his experience and practical knowledge with us in this free webinar in a truly engaging and powerful discussion. We will hear to Mr. MUJAHED HAMED. Mr. MUJAHED HAMED is a BSN, Certified Professional Healthcare Quality, Certified Healthcare and Hospital Safety, Certified Kaizen Lean Manager, Certified Healthcare and Risk Manager, Certified Key Performance Indicator Professional, Project Management Professional Expert, Certified as a Patient Safety Officer from AIQ, Certified Professional in Total Quality Management, and work as Deputy Director of Nursing and Nurse Educator. And also he is a nursing surveyor, ESR surveyor accredited by CPPS. He will talk today about improving the patient safety through effective communication. Important note before we start, if you are unable to join any live lectures for any reason, it will not the problem, as all our lectures will be recorded and will be available on the event page on the website within 24 hours of its live execution. And you can complete all lectures and submit all lecturer feedback during your subscribing period, approximately 55 days, to obtain your certificate of attendance for Patient Safety Awareness Week. Please don't hesitate to let us know if you have any concern. My contact are available in the website under contact us. Thanks to who care to join us. Wishing you the best. Reach useful. اتفضل يا استاذ مجاهد. استاذ مجاهد سامعني؟ استاذ مجاهد سامعني؟
نعم سامعك ابو الفتوح.
اتفضل.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
Thank you, Dr. Abul Futuh, for your invitation to be part of this greatest panelist in the patient safety awareness 9 days, as what you mentioned there. It's my pleasure to be with you, Abul Futuh. It's my pleasure to be in this group and to talk about my simple experience in medical field, in nursing field. And I hope I will learn from your side, and I hope this lecture will be informative. I know talking about communication is a simple subject, but the effectiveness and the importance of effective communication among the healthcare team, let me take this concern or this subject to talk about it. Since I'm working in Sibahi also as part-timer, I have noticed that many incidents happened in Saudi Arabia here in our hospitals, in private government and non-government also. It happened due to ineffective communication among the healthcare team. This let me take these incidents or these observations as a trigger for me to search more and more, and hopefully the information which I will give today will be informative to each and everyone, and hopefully those who are not implementing the handover or handoff tools will be able to start from today due to the importance of this subject. I will start here by the introduction that talks about communication problem with patients and within healthcare team are common cause of threat to patient safety. We know that communication, it is daily work. It is every now and then we communicate with people. You communicate with your colleagues. Wherever you work in the healthcare setting, there is more opportunity of communicating with others. Even you are in pharmacy, in laboratory, in nursing, in medical, there are a lot of opportunities to communicate with others. This communication, it should be effective to the level that I will guarantee that it won't cause harm to the patient at any stage of his journey in the hospital. We know that the patient, when he comes to the hospital, his experience in the hospital will help me as care provider to improve and enhance everything, even simple thing, even the way how he park his car, how he stop his car in the parking, even the way how he's received by the receptionist. All of these things are communication with the healthcare setting. So the importance of the subject in order to avoid any event of ineffective communication with the patient during the hotspots during his journey. Communication, like other part of patient safety elements, we know that communication having 4 pillars, and these pillars like innovation, like collaboration, patient and family-centered care, and communication. You notice that communication, it is one of the pillars. If you have a building and you are lacking one pillar or one column, the building will not be stable. It might fall at any time. So imagine that patient safety without communication, how the message will be relayed among the healthcare team, how it will be reached to the level that I am sure that the care given to me as a patient or to the patient in different place, that he is in safe hands. So communication from its simple definition, as what each and everyone know, communication is an act and art of giving.
معلش يا جماعه لو سمحت، بس اللي يخش يقفل المايك لو سمحت.
ليه؟
اتاكد بس المايك مقفول لو سمحت.
اركز على الكلام اللي قاله ابو الفتوح، اذا سمحتوا تقفلوا المايكات حتى انه ما يكون في ديستراكشن، لاني بفقد الايديا بعدين.
وبرضه معلش يا استاذ مجاهد، معلش عايزينك تبطئ شويه شويه بس.
سريع؟
ايوه تبطئ شويه معلش. اوكي
خلاص،
شكرا. شكرا.
Okay. So communication from it is simple definition that we learned it in the school when we studied nursing, medicine, or pharmacology. It is the act and art of giving and or receiving information. Why we communicate? We communicate to relay on or to respond to something or to know something which is not known before. So the information that which is necessary to reduce uncertainty, like to gain knowledge or to know something that not known as before. Uncertainty means that something unknown to me, that I have to know it. Example, I want to ask my colleague, what did you give to the patient when his condition deteriorated? What did you find? What was the vital signs that you have measured during the deterioration or at the point or the time of the deterioration? So he will give me the idea or the data or the information, I mean, that what happened to this patient. Now, the purpose of good communication, as what each and everyone also know, that to be able to reflect upon and exchange ideas. Every one of us, now I know many of the panelists, and when I listen to them, I will know more and more about them. Means that I'm communicating with them even from the screen side, but it is part of communication. What are we doing now? It is communication. So communication, as what I said earlier, it is the every moment activity that we do it. The communication challenges that we encounter in our life. Imagine when you relay the message to your colleague and your colleague will do different thing. How your feeling will be that moment? Imagine the doctor will tell his colleague that this patient he's for ECG, and if there is any changes, please relay it to the cardiologist. Imagine that doctor, he forgot. Hello. Imagine that doctor, he forgot to relay this message to his companion or to his colleague at night, and the patient at night deteriorated. His condition became worse. Then this patient transferred to CCU. In CCU, the condition deteriorated more and more, and patient died. Now, the ECG was supposed to be done earlier, that the doctor forgot to communicate it to his colleague. It's supposed to be the trigger if there is any changes in the patient's condition. So we know that due to the failure of communication, there was a problem happened to that patient. Now, imagine other thing that the nurse who's supposed to give the medicine to the patient, she forgot to give the medicine to the patient. And her colleague, she came, she found 2 tablets at evening. She said, I think the dose changed, so I have to give 2 doses or 2 tablets instead of 1. The nurse gave that medicine to the patient, then the patient developed hypotension. Patient's condition deteriorated and he was moved to higher level, higher acuity level. So the patient's condition now affected, means the patient who's our concern here, whom we have to guarantee his safety, was at risk due to improper communication between the 2 nurses and the 2 doctors happened earlier. Communicating patient information can be a very high risk process. Example, imagine the nurse will not endorse to the nurse in operation room that the patient doesn't have, or she didn't check the false teeth. And during the operation, at the beginning in the induction, the doctor is supposed to put the endotracheal tube. The false teeth almost fall in the mouth of the patient. Now, failure to communicate this supposed to lead to suffocation and as if for embodied airway obstruction to that patient who's now at risk of anesthesia. So due to inability of the nurse to relay the correct information about the patient, that incident happened. By the way, I will mention many incidents during my lecture here, which is related to the failure of communication. If we go backward to the Sentinel event and we look at the root causes of the Sentinel event in USA as what done by the Joint Commission, we will observe here as what you see that almost more than 70% or more even of the Sentinel event root cause analysis show us that communication failure was the root cause of that event. Imagine that the communication far bigger than the anesthesia care, far bigger than the physical environment, than the assessment, which means that patient is the target and he's the one who was affected due to the failure of communication. According to Joint Commission Accreditation and Healthcare Organization goals related to communication, they say that 66%, which is the report which was shown to you earlier, of sentinel event root cause due to communication breakdown among the healthcare team. Among healthcare team, they didn't specify that it's due to nursing failure or medical failure. Let's go to the national patient safety goals in states. There are international patient safety goals from Joint Commission International, which we are working on it in Saudi Arabia and in outside the states. They are talking about improve the effective of communication among caregiver through two important things, like the first one, which is read back, and the second one, which is handoff. Both of these will guarantee that the patient, the communication about the patient's care will be effective if we practice it properly. Imagine that a lab technician or a specialist will relay a critical value of blood sugar. And the nurse received from the unit, and she didn't write down, she didn't read back, and the technician from the lab, he didn't confirm. This means that the nurse could write different sheet, different paper, different file number, and she will relay different information to the treating physician. Why? Because she has failed to write it correctly. Because we know that whenever you receive telephone order, the nurse should write down, read back, and the one who called her should confirm what the nurse has written there in her sheet. The other thing, imagine there is no shift endorsement or handoff or handover. Imagine that the nurse doesn't endorse about what is happening in ICU, as example, that the patient will receive a lot of medications, and the nurse didn't endorse to her colleague what did he receive. This means that the care will be upside down, and no one knows what the patient received, what he will receive, and there is a great possibility of medication error. Let's go to the medication reconciliation. Imagine that the doctor in the emergency room, he didn't write the medication reconciliation in the initial assessment, which was done in emergency department. Medication reconciliation, I'm not pharmacist, but it is one of the most important subject that we have to do it before patient comes inside the ward. Why reconciliation of medication? I need to know what was the medication taken yesterday. What was the patient taking as regular medicine? Am I going to increase the dose, decrease the dose, omit the dose, or discontinue the medication due to his current problem? So if the doctor will not take these things into consideration, the other doctor who's in the ward, he might not think about reconciliation, and he will proceed some medications which contradict with the current condition of the patient. The other thing, it is encourage the active involvement of patient, family, and families in their care plan as one of the patient safety strategy. Now, JCI in the edition of the 2021, it is in the book of JCI, I will read it for you. It is 7th edition from January 2021. They added a new chapter. Actually, it is not a new, it is my chapter. They call it patient-centered care. Patient-centered care, it is a chapter consists of patient and family rights, patient and family education, plus the patient experience. Wherever you find in JCI word patient, means it is patient-focused standards, means that our target here is the patient. Now, it is not patient only, since we talk about families. Why? Because children, they have families. Vulnerable people, they have families. People who are old age, people who are at risk, people who are intubated, they have families. So we have to encourage communication with them. We have to involve them in the care process. This involvement means that I will communicate with them. Imagine I communicate and I give wrong information to the family about their patient. And I discovered later on that I'm talking about other patient. Now the doctor should come and he should disclose to the family and say that I am sorry, I apologize for what I informed you, that your patient was not this one. I was talking about other case. When I apologize for my mistake to the family will take it easy. They will forgive me. But if I deny this apology, if I don't inform them the fact or the correct things, of course, there will be more complaints and more problems. The other report from National Patient Safety Goal, it is the reporting critical values. All hospitals, they specify a list of critical values in radiology, in laboratory, in the area where the result will affect the life of the patient. Example, patient has done a CT scan and they discovered, or brain MRI, and they discovered that there is bleeding. Directly, the radiologist will call ICU, your patient having bleeding, he needs 1, 2, 3 as example, or he will relay it to the doctor. So the doctor in ICU will be ready to intervene or to act accordingly. The other thing, verbal and telephone orders. We know that verbal and telephone orders will not be used unless an emergency. Unless an emergency. Doing these things without following the guidelines of verbal and telephone order by writing down, reading back, and confirmed by the sender, it will be failure of communication, and the error is imminent and could happen at any time. This is the report of the Joint Commission Accreditation. As what you see, they have studied around 3,000 sentinel events, and they found that 66% of them found that the communication failure was the primary root cause. Imagine out of this, let's talk about 2,000 sentinel events, 75% of them died due to failure of communication. Now, people is not dying from COVID only. They are dying due to failure of communication. So improving effective communication became one of the most important IPSGs. And in the sequence, it is number 2. IPSG now, number 1, identify the patient correctly, then ensure effective communication. So let's think about it, how much it is important from this point. There is another study done in Australia also. They found that the communication problems were one of the 4 main categories associated with adverse event. And we are talking about states, we are talking about now east, about southeast, which is Australia. And they have studied this one and they found that communication is a big problem. Let's talk about Germany. They found that 15% of the event were related directly to problems of communication between care providers and patient, family, or within the team. So imagine that more than 50% was a contributing factor. Means that the nurses, the doctors, and others who are not communicating well, they are the people who are causing this incidents. Here, ineffective communication and lack of disclosure. There is transparent when the hospital working as a transparent hospital. Transparent means that the hospital disclose what is happening there to the family of the patient, to the patient. So ineffective communication and lack of disclosure are the most prominent complaints of patients and their families who are victims of medical error or negligence. Imagine that. Lack of disclosure because they are not reporting what is happening. Ineffective communication will lead to errors. Who's the affected person? Not the family, number 1. No, he's the patient who might lose his life. Let's talk here about the family engagement in the process. Patient and family, they are advisors for improving the care and safety. How? Because we have the patient experience, we have the patient's journey, we have the questionnaire. We in the hospital where I work in Riyadh, we are using the high caps questionnaire in order to get the feedback of the patient about the communication. We have it there that communication of nurses in delivery room, communication of nurses in the emergency, in OPD, communication of doctors, the same thing, in delivery room, OPD, ER, surgery, medical, everywhere. And thanks God, that one gives us a trigger or provoke us in the hospital to enhance a committee called Patient Experience Committee. And we have members from each discipline attending with us. So he will know where are we, where were the defects, and how we will improve it. The other thing also here, which includes the sharing or the engagement of the family, patient and family, is the handoff. Handoff, it is between nurses, between doctors, that will involve the patient and the family. Many times I have attended this one in the hospital. If the patient is alone in the room, the handover could be done inside the room. So the family, they will ask during the handover between the two nurses, between the two doctors, they will ask, and we have to involve them. We have to reassure them. We have to tell them the care plan for their patient. And these things, all of it will happen between two care providers or more inside the patient's room. So again, Joint Commission International, they focused recently about the participation of the patient and family in the care process. And they asked us to show them the evidence that really you have participated the family in the care decision. And actually it is one of the important standards there, because sharing the family or involving the family or engaging the family in the care decision will keep the outcome more successful. Then also here, the engagement will lead to help to create an environment where patient, family, clinicians, and hospital staff are working as partners. So at the end, they will help all of them to improve the quality and safety in the hospital setting. Actually, I will go back to that slide and I will talk about the discharge planning. We know that discharge planning, it is important in the patient's journey in the hospital. Why? Because discharge planning, if not started from day one, from point zero, as soon the patient will be admitted, of course, the outcome will not be good. It will be very poor. So the discharge plan will be explained to the patient, what are we going to do for you? How many days you will stay in the hospital? What is the operation will be done for you? How much your recovery? How much you will lose blood in the operation? How much, who will take care you at home, who will take care at home when you go home? Who's the one whom we will teach him? Who's the one whom we will inform him as you wish to receive the information about your condition? So imagine this one in the discharge plan. So if we follow this one, the ideal discharge planning technique, which focus on the including the patient, discuss everything with him, educate him, assess him, and listen to his concerns. How many times patient will change the care plan? If the patient will not participate in the care plan, he will be forced by the doctor or by the nurse to get the medicine. This is the reason why we have a standard in Joint Commission that the patient having the right to refuse the treatment. And the hospital must give him the alternative or the choices inside the hospital or outside the hospital. So you have to think here how much we are engaging the patient and his family in the care process. Now, failure of communication or breakdown effect of communication will affect the care process. So failure to share the vital information among the multi-team system will be also trigger and provoke the hospital that there is incomplete information, incomplete process of transition of care transition among the healthcare team. So sharing the information, it is important. Not doing it, considered failure. Failure to request information from others that required for wise decision making. Example, the patient will be referred for other doctor. If I am the treating physician and I consider that this patient will be treated only by me, where in fact I think that he needs second opinion and I didn't give him, this will be violation of his rights. So failure to request information from others that required wise decision will be considered a reason of communication failure. Your patient deserves to check for second opinion. Why you denied his right? So we have to follow it, we have to do it, and patient should, the hospital, as what you know in private sector, they will not shoulder any expenses of the second opinion. So it is his right to get it. So if he will not get it, means that I didn't relay the proper communication or effective communication in my work. Failure to direct information to a specific team in the timely manner when needed, of course. The information will be given when that critical value from laboratory, patient's potassium was 1. It is a critical value. Patient's blood sugar, it is 1 millimole, or let's say 0.5 millimole. Patient's sodium, it was 170. Patient's creatinine, it reached to 800, 900. All of these things, or blood sugar as example, reached to 800, 900. All of these things, critical values. If I don't relay it to the doctor on time through following any hand-off tool, as example, SPA, it will be failure of communication. And who will be affected? Of course, the patient. Failure to involve patients and their family in their care plans, like no seeking of patients' input. Imagine the patients having no right to, by the way, I have a prayer time now. Is it okay to continue or to stop?
زي ما يعجبك. شوف انت
I don't know if it
عايز
is clear for
تدي
you.
ده اللي يعجب حضرتك بقى.
I will proceed. Okay.
خلاص عايز اوكي بروسيد مش مشكلة.
The patient will say either me or no one, right? Either me or no one. If he's not involved in the care process, how he will comply with the request of the doctor, right? So any failure of involving the patient in the care process will affect also his safety or his health later on. Here I have some factors. They determine the communication effectiveness and comprehension. I will just pass by it. It is time and urgency, culture and ethnic, socioeconomic, literacy, gender, personality and behavior. All these things, each one of us having it. Each care provider might work on this one. We know that as much the, let me say that the urgency for communicating effectively, it is important here in order to get enough information for the next step. If the time is not consistent with the deterioration of the patient's condition and reporting that deterioration to the treating physician, it will be too much important on patient's safety, on patient's health. So he might die because patient, I left him. I will tell you an example happened in one hospital. There was endorsement or handoff or end of shift report between the nurses. Patient was post-cholecystectomy. The doctor told him, tomorrow you will go home. Then at around 5 o'clock, the patient complained of shortness of breath. The nurse didn't take it into consideration. She told him, change your position, upright, you sit in upright position, and you will be okay. The patient was left unattended for 1 hour, 2 hours. At 7:15, the shift started. They went to the room. They found the patient blue. Patient developed pulmonary embolism. They called the code blue. They started resuscitation. They transferred the patient to higher level, to ICU. Patient during ICU, they intubated him, connected to ventilator. At morning 6 o'clock, patient died. This showing us that the importance of relaying the message from the patient to the treating physician and the proper action to be done on time. It is his fate to die, but do you think he died with reason? There is a reason for death, but due to the negligence of the staff who have worked with him. Other thing, yesterday in Jordan, or on Saturday in Jordan, I'm Jordanian, there was a big hospital near to Amman. That hospital recently opened. At 6:30, the oxygen tanks, they have 2 tanks, emptied from oxygen, no more oxygen. They have many patients, COVID cases in ICU. They lost 9 cases. 9 cases, 9 patients died. Imagine they went to be treated in the hospital and they died due to ineffective communication among the team. The charge of the oxygen cylinders or oxygen tank or PMG, pipe medical gases, he didn't report the low level of oxygen at evening on Friday. So at morning, no more oxygen. We know that the pipe medical gases, you have the tank, and when the tank will near to finish, there are also cylinders. that should satisfy you for 48 hours. It was not happen. Why it was not happen? Because that guy didn't communicate with his boss. The boss didn't communicate with the company, and all of them slept in honey. And who have been lost? The patient. We lost 9 patients in that hospital. So this shows us the importance of the communication among the healthcare team. It is not only nurses and doctors. There are nurses, doctors, gas technician, kitchen, everywhere. So we have to think about these things when we talk about communication. According to the Stephen Covey, who is the author of the 7 Habits of Highly Effective People, I love this highly effective people because this is positive. He says that effective communication may require more upfront time, but ultimately result in a fewer misunderstandings. We might need more time to communicate effectively, but I know that it is not useless. No, it is very expensive and it is important, because if we spend long time to endorse, I am sure that what I relate to my colleague or my patient will be in safe hands if I relate to him everything. An effective communication, often resulting from attempts to be efficient, is hurried and can lead to poor understanding, confusion, delays, mistakes, and anger in emotionally charged situation. We know that in effective communication, it is killing. It is killing because it is not efficient. It was done in hurry. It is not clear. Imagine these things happen in the care setting. Imagine the doctor, he's in a hurry to bring his children from the school. Hopefully the school will go back, will start again. He went to bring his children from the school. He's working in ICU. Then he didn't endorse to his other colleague about the needs of his babies there in the unit. And his colleague, he thought that he took care completely of his babies, or the babies there, the prematures there in ICU. But unfortunately, he didn't. So the care given there is not complete due to the ineffective communication. Let's talk here about the strategies for communication improvement. The goal of use of these tools is to potentially reduce the errors. We don't want to reduce the errors. We want to make it 0 error associated with miscommunication and lack of vital information. So the scientists or the people from everywhere, they are talking about many tools for handover or for handoff, let me say. One of these tools, we call it SPAR. I will explain it at the end in details. SPAR, consists of situation, background, assessment, and recommendation. You might find it in the market or in some hospitals. SPAR I, which means introduction, or SPAR R, which is a report at the end, or SPARK, which is Q at the end, question. So SPAR, it is the simple wording that is used for handoff or for reporting emergency situations, especially whenever there is some problems happen to my patient and I have to relay it to the doctor as soon as possible. Call outs, it's direct information to a specific person to raise his attention to correct his action. I will tell him what to do for that point at that time for that person. The checkbox, it shows me show me what did you do. Check understanding, which is the confirming that he knows what you told him, and the feedback that he's going to implement what you said. There is also another, by the way, there are many tools of handover, let me say, or the communication among the team. Handoff, there is something called I pass the baton. As what you see down, introduction, patient, assessment, situation, safety concerns, the background, action, timing, ownership, and next. I cannot explain these things because there are many, but this is one of the beautiful tools that we can use it in healthcare setting. By the way, handover or SPAR or these things, it was started not in the medical field. It was started in other field. as what will be shown to you later. So these tools can be simply implemented and integrated in daily practice to improve team performance and outcome. JCI, Sibahi in Saudi Arabia, Australian accreditation, Canadian accreditation, they don't mandate any tool of handover. They leave this one to the hospitals to select their own way of doing handover. Why they don't mandate these things? Because sometimes some parts of the tools is not applicable. So you will do it based on your side. As example, the handoff sheet of the pre-op preparation, it is different from the one that they do handover in the unit. The one when I send the patient to the operation room, I need to talk about many things. One of them is the verification checklist. One of them is the patient having antibiotic. Did they sign the consent? The patient having a gold or remove false teeth, or patient have contact lenses. All of these things part of the handover. Imagine in Sibahi, we are specifying the pre-op sheet to include whether that statement that required to check is yes, no, and we mandate not applicable, right? Why not applicable? We don't leave anything in the pre-op checklist blank. For what? In order to ensure that the patient who's going to high-risk procedure, which is operation, is properly handed to other care provider. So the error possibility will be minimized, even it will be zero, as what each and everyone expect. The goal of handoff, it is to enhance the information exchange among the team about patient's care, about his condition, current condition, about the treatment, about the changes which could happen. And I will tell you something, it is not only about the anticipated changes, about any unanticipated changes that could happen, which is mentioned clearly in the Joint Commission, and it is mentioned also in the Bill of Rights as per the Joint Commission. And the contingency plan recommended to maintain the continuity of care, despite of the changing caregivers, like unfragmented care. Example, what is the contingency plan? Let's say that the patient, he doesn't want to be operated. So what the doctor will tell him, he will explain to him that if you will not be operated, the stone will become bigger, your complaints will become bigger, and you might develop severe renal colic due to increasing the size of the stone. So what is the contingency plan here? I think the contingency plan here should be as per the patient's preferences. We should respect his preferences. Imagine if you want to give him food, you will ask him which food you like, which food you don't like, which means that I have to contact with him and I have to communicate with him. I have to relay my comments or my finding to my dietitian supervisor. My patient, he needs this kind of food. It is not like that only. I have to communicate with a treating physician. Hello, doctor, does it contradict the mode of treatment that you are doing to your patient? Or if we are in ICU, we know that there is every moment handoff. Due to what? We are having a grand round in ICU. We have multidisciplinary care meeting. We have end of shift endorsement. We are having changing whenever we bring the patient from other place, or when we send the patient to the unit, lower acuity level. So imagine here that everything during handover, even anticipated or unanticipated, I have to explain it to the other care provider. Example, also, my patient, he's in ICU and he will be moved or transferred to the ward. The nurse in the ICU, she has noticed an area of redness. This redness area, it is blankable. It means that it is not area of pressure injury, but if it becomes red, it will be an area of pressure injury. What is the anticipated here? If it is blankable, it is developing pressure injury if left not turned. What is the unanticipated? What is the unanticipated? That this place, you might come and see it necrotized due to not changing the patient's position. So these are one of the things which is happening during nursing handover or handoff. Since 2003, implementation of regulations limiting hospital staff duty hours, which has led to greater discontinuity among resident physicians. Now, if you look at the time that the government gives to the, as per the labor law, that each employee should work 40 hours per week. Now, based on this one, and each and everyone knows that the curve will start to drop after 5 working hours. And this is the things which they say in everywhere, all over the world, even in Emirates, even in Europe, even in States, that the staff, when he reach 5 hours, I have to give him break for 30 minutes. Why? It is like top loading in order to get more energy, to get a break and eat, right? Imagine I'm extending the duty hours to 12 hours. I will show you here. I think it is, I will show you it to you later on. I have a screen showing us how much the errors of communication when we increase the working hours by the healthcare providers. Here, the tools for transferring of information along with the authority and responsibilities during transition in care across the continuum of care. This slide, it talks about the importance of handoff and where it will be happened, and include an opportunity to ask questions, seek, clarify, provide confirmation. All of these things are communication with each other in the hospital. Imagine we have also communication between the doctor and the patient. Do you remember the IHI when they say, ask me 3? Actually, this Ask Me 3, I appreciate Dr. Abul Futuh because we have done it in our hospital and it was successful. And thanks God, we have received excellent feedback from the patients and from the families also about Ask Me 3. Here, I say that to ask the patient and consider this as a handoff. No, ask questions to remove the uncertainty. So if there is uncertainty, there will be problems happened in the care continuum. In the transition of care, as shift change, the risk may present, especially if the necessary information about patient might not be communicated. Regarding to Joint Commission standard, each institution is mandated to implement handoff communication. This one, I explained it. The handoff will decrease the shift houses. This one also about the hours. And if we are not taking care of the hours of the duty hours of the care providers, of course, there will be possibility of errors. Handoff, the process of transferring responsibility or authority between the care providers during hospitalization. This other sign out, you remember in the verification checklist, as per the WHO, World Health Organization, we are having sign in, sign out, and time out. Sign in, time out, and sign out. Sign out, it is the process or act of transmitting information about the patient between and among caregivers during hospitalization. Let's take this example in operation room. Sign out, this means that the operation has finished and now the patient will be moved to other level. In the sign out, it is type of handover between whom? The operation room and the recovery room. So any deficiency there, example, any deficiency will lead to error. Example for that, imagine that the doctor inside the OR, he said, do not activate the JVAC unless 30 minutes after operation. The nurse of OR, she forgot to inform the nurse in the recovery room about activation of the JVAC. The nurse of recovery room, she didn't endorse to the nurse of the unit to activate the JVAC. Patient will be sent to the unit, patient in the unit, no ice pack applied to the ACL operation as example, JVAC not activated. Now patient left unattended for almost 12 hours. They will come, they will find that the patient's leg is swollen, bleeding, oozing from the wound, and patient having severe pain. Why this happened? Because the doctor, the nurse, they have not handed or they didn't endorse properly about what action to be done. So this one considered as an unanticipated thing that happened due to the carelessness or the negligence of the care providers. Communication failures between providers have been found to be a leading cause of preventable error and studies of close malpractice claims. Imagine here in Saudi Arabia, I know some cases due to failure of communication, they paid a lot, and they have been moved from their place to lower place. They have been demoted. Why? Because they failed to communicate effectively the patient's condition to their colleagues. This is the slide which I told you. Risk of error almost doubled when nurses worked more than 12 hours consecutive duty. Look here, less than 8 hours, the errors are less. It increases when we get more working hours. Increases also here, you see, to 7% of near errors when we lose our focus. As much we do duty, as much my duty, don't be happy of overtime. Overtime, as much you will get, will let you pay it back if there is any error happen during your time. I don't say that we have enough manpower in the hospitals. No, I don't say like that. But I am urging the nurses, I'm urging the doctors, try not to keep yourself in the work every day, every now and then. Why? Your body will get tired. Your mental stability will be affected. You will do mistakes. You will be called to the court. You will pay for the malpractice. You might be in jail one day because you have done great or big mistakes that let your patient die. So what's the benefits of the money compared with the safety? I think it is nothing. Here about poor disclosure after medical error increases the potential risk of litigation of malpractice. What I mentioned earlier, this is the slide which is summarizing it. So poor communication will lead to 27% more safety events if it comes to the nurses, and 15% more safety events which is related to the doctors. For me, if you want me to tell you, here in Saudi Arabia, I think nurses, it could reach 60%, doctors to 40%. I don't have a study, but I guess it is like that. Why? Because here, there is no principled work in many settings. As what I said, I'm visiting many hospitals. There are excellent hospitals who are doing the handover and handoff, let me say, very well between each and every one. But in some hospitals, till now, they didn't develop policies for handover. Imagine that. Effective communication, as what each and every one knows, that to hear what is not being said. Why we catch our mobiles, we open Facebook, we open Snap, we open Instagram, we open these things. We want to know many things about people, right? Now, if somebody asks you, tell me, would you please, if you close the camera, Mr. Majdi Fathi. Okay, so each and everyone will go to the social media to know something. Example, I want to know some news from one place. I will open, give me that news. Example, I want to study something. Easily you can open it and know it. So it is considered communication because you are dealing with the media. You are dealing with the social media to get your information. Effective communication, how I guarantee that my communication is effectively done? When it is timely, the time I need it, when it is accurate without bias, when it is really about the patient's condition, what happened, when it is complete. We know there is something A, B, C. I remember this one, it is not airway, breathing, circulation. Whenever it is accurate, brief, and concise. This one about documentation, but it is implemented in many settings in medical field. So it should be timely, accurate, complete. Unambiguous. When I endorse to anyone, I have to remove the language barrier, and I have to be sure that the idea was relayed correctly to that person. Otherwise, it is unambiguous. It is not clear. Understood by the recipient. This is the reason why you have to ensure the feedback. We do decoding, encoding, and decoding. We have to be sure that the response of my colleague was accepting what happened. Reduce errors. What does it mean, reduce errors? As the communication was done correctly among the team, as much the handoff done correctly, the possibility of error will avoid giving the patient double dose. The communication, the effective communication that I used will minimize the risk of patient's condition deterioration. So I don't need to let that patient of cholecystectomy who's supposed to be handled well to be moved to ICU. He lost his life. Why? Because the nurse didn't report to her charge nurse what happened to him. Results in improved patient safety. Of course, this is our goal. We are aiming, all of us, to improve the patient safety. So patient safety, it is not one-man show. It is multidisciplinary efforts by each and every one. Imagine patient safety, it is the role of the security in front of the hospital, on the gates. It is the role of the admission office. It is the role of the guard. Everyone working in the hospital, he has a role to improve the patient safety. Oh, it is big storm. Imagine you are driving. This one is not in Saudi Arabia, of course, not in Arabic country even. Imagine that you are driving, then you face this big stone. You are in hurry to reach to the other side. What do you think you will do? Are you going to break this stone? Stone is too big. You don't have axe, you don't have hammer, you don't have anything. You will walk, you have car, you need to reach very fast. I give this introduction about the communication barrier. Imagine you are teaching someone and he doesn't understand. Do you think you will bear him? You will not be satisfied, but you will give him opportunity, but he's not understanding. Are you going to let one nurse who doesn't know English to know English? No, but you have to communicate with her as per her level. How? Get translator, interpreter for her, so you will not be in trouble with her. The same thing. This one, try to go back, check another way, try to walk, try to do something to overcome the barrier which you face. The barriers in to do effective communication, as well, each and everyone knows that if we are using different language, different terminology, different way of understanding, of course, it will be a barrier for effective communication. Now, all hospitals in Saudi Arabia, they mandate that all healthcare providers should talk in English language. Imagine in the handover between morning and night, we have Indian nurses, Pakistani nurses, Egyptian nurses, Filipino nurses, and they are not talking in English. Why? Because the charge here and the charge there, they are from one nationality, they talk in their language. Do you think the care of the patient will be safe? I don't think. Too many words used like inarticulateness. As what I said earlier, if you want your communication to be effective, it should be timely, accurate, concise, and brief. So if you are not doing this strategy when you do handoff, I think the same thing, there will be problems to your patient. Personal, cultural, or experiential differences. Each and every one comes from different culture. Even the pronunciation will be different. So it will be considered as barrier of communication, effective communication. This is the reason why we teach our new nurses who arrive to Saudi Arabia how to communicate effectively. We teach them even Arabic language. We let them be with Arabic speaker staff in order to let them learn how to communicate with patients. Physical or emotional distance. All of us, we believe in this, that there is something called tender loving care. Tender loving care, when the child will cry and his mother will hug him and put her hand on his shoulder, I think the child will stop crying. Isn't it? I'm not saying to hug each and every one, which is not allowed now in COVID. I'm saying these things as much you are nearer, as much the emotions are mutual, I think the communication will be effective. Lack of interest or preoccupation. There is said that don't carry two watermelons in one hand. You will lose both. The same thing, you cannot have two minds at the same time. You are talking to your colleague and you are endorsing to him about other patient. And the nurse, she's writing in the handover sheet. So when you go to handover, just empty your mind only for this purpose. Hostility, hidden agenda, or defensiveness. All of these things will give false judgment. So it will be considered as ineffective communication or barriers for effective communication. Tendency to make false judgment, interpretations, or assumptions, also considered as part of the barriers. So don't decide something that you didn't test. So you have to, even don't rely on valid and reliable. No. You have to test what are you going to get. The doctor endorsed that the patient will go for operation tomorrow. Go and talk to the patient. Take again another history from the patient. This will not harm, but it will enhance and enforce the knowledge and information you have about this case. He might tell you different information than the one who collected in the initial assessment. That will affect the next decision, and he might not go for operation. Good communication will not take place if people do not really listen to each other. This is clear. If I don't listen to you, how I will relay the care properly to my patient? Here I talk about the fatigue. You remember before when we talked about the hours of work. As longer hours you stay at work, as more errors you will have. I did roughly, it is not actually study in my workplace, and I have noticed that the nurses will do errors mainly after 5 p.m. I didn't do it a study, but because I'm working as deputy director in my hospital and I'm responsible to investigate the complaints and the incident reports. I noticed that most of errors happened after 5 p.m. This gave me indication that when the nurse becomes tired, she will lose her focus, and it will be easy for her to forget. It will be easy for her to do the mistake. So how do you think if she's working long hours, she will endorse? What she will remember, she will endorse, but the important thing she might forget. Cultural norms also. We have, unfortunately, some people, they don't believe in the transition of care. So they will say, what's the benefits of doing handover? The patient, he's long-term, today like yesterday, and today will be like tomorrow. So why you have to spend time to handing or to do handover to you? Multitasking. This one is the one who's carrying many watermelons in his hand. It will be considered as a barrier of communication. Stress. This is the reason why we advise our people, when you are stressed, calm down or take a rest. Don't come to duty unless you are properly rested. Different accent, the same thing. This one, he's even people from India, they're talking different way. Even people in Saudi Arabia, they talk in different way, north different than south. Dialects, pronunciation, the same thing also. All of these things showing us that the way of communication, if it is not effective, it will be lead to errors. Physicians and nurses are trained to communicate differently. Why? Because of the multicultural and multi-background. We have something in nursing, actually. Nurses, unfortunately, they feel intimidated when they relay information to the doctors. So this one will be a barrier to effective communication. Why? The nurse will feel shy. How I will endorse to the doctor? How I will tell him, your patient having right upper quadrant pain. Your patient having, his pain score is 8 out of 10. Doctor, come, your patient is complaining. If the nurse is weak, she doesn't know her responsibilities, her patient will be lost. Her patient could reach to sensitize to a condition called sensitization that even you give him morphine, he will not respond to it properly. About the communication that I think we are having here common problems that we encounter when we communicate with each other, like lack of listening or premature interruption of the patient's talks, use of medical terminologies or jargons. Also, these are as barriers, lack of interest or compassion, lack of attention to the patient's view. All of these things as barrier of communication. Also, in addition to that, the problems which we encounter when we communicate with patients, it is the disregard of communication handicaps, the patient like foreign language, hearing loss. I have recently, we hired a group of nurses from one country. The last month, a questionnaire given to the patients, they reported that your new nurses are not knowledgeable, are not communicating well. This one, because they are not familiar to talk in Arabic. So this reflected badly on the reputation of nurses. So what we did, we have decided to make task force to let them be taught by the same nationality, from senior staff from the same nationality, and one of the Arabic instructors will be with them to teach them how to communicate, how to deal with patients in order to avoid the problems that we encounter with them. Omission to verify that the patient understood the information presented. We have to ensure patient understanding, isn't it? In teaching record, we have to ensure that the patient was learned and he's able to reflect upon. Lack of time available for the patient. It is a problem. We have to offer him enough time because it is also communication opportunity. Actually, Abul Futuh, my screen is not appearing properly here.
لا ready appear.
Okay, now. Do we have safe and effective communication? Let's think now about areas where we can improve to ensure effective communication. Let's talk about patient-related factors. Are there barriers to communication like language? We have to think, what do we have here? Why this patient complained that the care given to him was incorrect? Why the medicine given to him, the take-home medication given to him, it was wrong? Why the patient who was sent to OR, it was not the one? So what are the barriers happened between the nurse and the patient? So there is something here related to the patient himself. Did the patient understand me when I communicated with him? Why the patient didn't start NPO status when I explained to him? So why the patient attention was not here? Why the patient, when I explained to him about the preparation for OR, he didn't follow? Here I have to think, where is the defect? The defect here is the care provider. He has failed to relay the message in the language that is understandable language to his patient, which led to that delay of the care. Are there tension in the doctor's patient relationship? We know many patients, especially if you are in private sector, what they do, if the doctor is not organized, the doctor doesn't come to see the patient on time, they will call the social workers, sister, I don't want this doctor to come to me again. Okay, what do you want? I need to be transferred to another doctor. You know, due to this reason, the patient selected another doctor, where in fact he came for that physician who's the first one, but unfortunately, he didn't give him the time that he needed. So we have to think in the hospital how we will improve effective communication between the care providers, including doctors. We have to relay the message of the patient through the ongoing physician performance evaluation. Doctor, you are having here 5 patients who have been admitted for you. They have requested to change you to another doctor. Give me an answer. This one will affect your evaluation. This one will affect your incentives. Imagine this one who reported to me, the patient. So the one who reported here is the patient or the family, which means that the way of communication between the doctor and the patient didn't reach to the satisfactory level and led to change him. Something related to task-related factors. Example, lab, pharmacy. Are laboratory results correctly communicated and understood? I have to think. This one for the root cause analysis. Why the patient received wrong dose of normal saline hypertonic, where in fact the result of that patient was not for him. Imagine you give 3% normal saline to a patient who's having normal sodium level. What there will be? Isn't it his brain will be affected? His blood pressure will suddenly increase and he might develop stroke. Isn't it he might lose his life? Are there protocols and procedures for handover? Do we have handover in that hospital? Or things will be done randomly? Or patients will be discharged without anyone? Or the care will be moved or given to other patients because there is no handover? By the way, here I want to focus on one important thing. Unfortunately, in our countries, in the Arabic countries, till now we are using the room number. Using the room number in communication among the healthcare team, it is a big failure. Again, there is no study. I'm saying these things, it is a trigger for you, my colleagues, and everywhere, that let's study this one. Let's study this one. I think it is too much important. Why the nurses and doctors till now they use the room number in their communication? Why we didn't use the patient's 3 names and the medical record number as a way that is guaranteed will not lead to error? Imagine these things. If you do it, inshallah, I'm sure that no errors will be happen to any patient related to the patient's identification, which means that, or of course, it is with communication as the other side of the coin here. Individual factors of staff member. Do we train our staff about communication? Do they know how to communicate with patient? Do they know how to initiate report when they enter the room? Do they know how to relay the message to the mother of the child? Do they know how to explain the medication when the patients will go home? By the way, one of the main measurements we do it in the high caps in our hospital is to measure the take-home medication understanding that the nurse has explained to him in the way that he understood or not. Thanks God, in the hospital where I work, the result is good. But I think this is communication also, communication between pharmacy and the nurse, nurse and doctor, nurse, doctor, and the patient. Because imagine you give wrong medication to the patient due to communication problem. The pharmacist who's preparing medicine down in the pharmacy Instead of put the sticker of patient A, he put it on patient B. Then the nurse, she gave wrong medicine to the patient. Why? Let's go back to the working hours. That pharmacist, he's having 16 hours duty because he will go to his family. He will take 2 days off. He did 16 hours duty. He lost his focus. He issued wrong medicine. If you study it and implement 5 whys or root cause analysis in general, you will find that the fatigue was the reason of that errors, which was reflected badly on that patient who was given wrong medication. Team factors. Do staff communicate effectively in the healthcare team? Or Indian will talk Indian, Filipino, Egyptian, Jordanian. So what I mean here, that the communication among the team should be uniform language. Workplace factors. What are the workplace setup? Is it problem inducer? Is it a problem waiting to happen? What about the workload? How much the nurse walking per shift? In football, when you play a football game, match as example, they are putting a machine on the players to measure how much they run in the playground. Imagine you put it for the nurses and ask her to measure how much she walked in her unit. I will tell you something, guys. Many nurses, they walk more than 10 kilometers per day. Many nurses walking more than 10 days. It is not healthy walking. It is stressful walking during the work. Did we study this one? Did we know the risk of errors that could be generated due to this or not? The stress in the work. My head is always interfering in each and everything in the work, which let me be distracted. Even I will lose my concentration. I cannot communicate with anyone. When I communicate with the doctor, I will find many people interfering and interrupt me and him. I cannot get the complete statement from him that will be affecting the patient's life. Imagine I am in the station. I want to inform the doctor about emergency situation happened. Then I called him, and the station where I work, full of doctors, nurses, receptionists, billing staff, everyone talking. I cannot get him. So it is noise at work. Did we measure how much noise we as healthcare providers we encounter per day? Do you know that if you encounter more than 90 decibel of noise for 8 hours, you should go home? Do you know this? This one from OSHA. We don't measure how much noise we encounter in our work. I'm talking to you by my emotions because really many people, they are working very hard, especially nurses, because I am a nurse actually. They're working too hard and they encounter a lot of stress in their work, and we don't even consider that. The people, they want the nurse to be smiley face all the time, and at the end, she will do the mistake and they will blame her. So it is an area of study also for us. Other things, it is organizational and management factors. Do we have culture of safety in the workplace? Do our managers are committed to the proper communication and effective communication between patient and within the staff? We know that effective communication policies should be signed by the higher or by the top management. We know that IPSGs, it is safety issues. It should be signed by higher level. It is not only signed by them. It should be practiced by them initially. It should be by them. Then after that, I will follow, because the managers are the frontliners of the institution. If they don't know how I will maintain the safety of my patient, what is the end? I think each and everyone will be at risk. I will skip this one. I will go here to the handover. Just more elaboration about it. Handover notes.
استاذ مجاهد الصوت بس. استاذ مجاهد الصوت لو سمحت.
Is it okay now?
ايوه كويس كده، اتفضل.
Okay. I'm talking here that one incident happened in one country. It is related to narcotic cabinet. The charge nurse who handled that narcotic, it is part of the communication among the healthcare team, because you will endorse or you will handle the workplace, the structure or the physical structure of that place. Because in moving away from one shift to another shift, you will handle you will make handover of the patients and the unit, especially if you are having narcotics in your area. What the nurse did, from the window, he threw the key to his colleague who's coming to duty, right? And he went home, the one who was morning duty. The one evening duty, he came, he didn't find the narcotic cabinet. Somebody removed it totally. Now, who's handling the keys? The new one who came. Where are the narcotic cabinet? It was taken by another person. Imagine that it reached to police. This one in one country, I will not mention the name. It reached to the police, and it was done just kidding of that person. Imagine why it happened, because they have done the handover as shortcut, which led to police. It led to big problem to both of them. Imagine that. So handover, it is a transition period that each and everyone will endorse and make sign out. Bye, I'm going. Do you want anything? Khalas, when I give you the give you the endorsement needed about that cases which I have or about our work, means that no more responsibility from my side to sign out. Handover is transfer of responsibility and accountability of all aspects of care for a patient or a group of patients to another person, team, discipline on a temporary or permanent basis. Okay. Also, it is transfer of all relevant information about an individual patient. In addition to that, effective handover is required when patient moves between areas of the hospital to other, as example, from ward to endoscopy, from theater to ward, from ICU to ward. Here, I will focus in CPPS. CPPS, they have requested a special handover policy in each critical care unit, like ICU, PICU, ICU, and CCU. Why they requested these things? Because when you move the patient from critical care area to lower acuity level, the nurse in the lower acuity level will not understand you. What do you want? What parameters I have to measure as a recovery unit? Because it will be considered as a recovery unit after the critical situation. So we designed for them special format that they use it when they move the patient from critical care area to the general area. Because general area, it is simple paper, simple handover sheet that they use it, which will give the information about the procedures, about the findings, about parameters like that, but it doesn't go in details like the one in critical care area. Clinical handover provides the opportunity or excellent opportunity to ensure that the patient and family and care providers are involved in and informed in the care treatment decision. I think this one I explained. Here, let's look at this statement, which is too much important. I love it. Empathy, listening, and communication to patient and family as advisor for improving care, quality, and safety. What does it mean, empathy? Empathy means that I will feel there is another thing, says that put yourself in the shoes of the patient. You have to feel what they feel. If you feel like that, of course, the error possibility will be less. The safety will be clear, will be received. Let's go to the bedside shift report of the nurses. The goal of bedside nursing handover or shift report strategy is to help ensure that safe handoff of care between nurses by involving the patient and the family. The involvement here, it is not simple like this one. It is engagement. Engagement means that you will let the patient decide also, let the family decide, let them be the key persons in the handover process. In the hand, whenever the patient and his family are exempted there, they might deny the care. Do you know that the patient should give you the approval for any procedure you want? This means that he was part of the procedure. If he doesn't want to get his medicine on time, he's having the right. And I have the right to let him sign for me, release from liability. But I have to engage him. I have to get his preferences. Help to create an environment where patient families, clinicians, and hospital staff working together as partner to improve the quality of safety of hospital care. So this is the purpose of it, and I discuss about the discharge plan. Here I will give an example about one of the handoff procedures or tools that we use it, which is SPAR. It is a useful structure to employ when nurses, doctors, and or any member of the clinical team need to communicate about patient's condition. SPAR, it is a technique that can be used to facilitate prompt and appropriate communication. It allows important information to be transferred accurately and situational briefing model that provide a common, predictable structure of communication. Do you think SPAR is nursing tool? No, it is not nursing tool. Do you think is it for doctors? No, it is not for doctors. Do you think it is for pilots? Of course, for pilots. Do you think it is from Marines? Yes, from Marines. Who are the people who started these things? SPAR was first developed by the military in United States, specifically for nuclear submarines. So it was started in military. It was used in the aviation industry, which adopted a similar model before it was put into use in healthcare setting. I admire aviation. Why I admire? Because I like it. I supposed to study pilot, but unfortunately I didn't. Aviation, it is very critical industry, and it is based on checklist. What does it mean based on checklist? Any process in our life, you have checklist for it, I think it will be successful. You know where is the defect, how you will solve it, and you will be organized. So this is SPAR, it is organized exactly. I will go in details later also. It was introduced by two rapid response teams at Kaiser Permanente in Colorado in 2002 to investigate patient safety. Of course, rapid response team also, it requires SPAR. We are implementing it in our hospital. It was recommended also by UK, by London, to use this SPAR during the handover of care between medical teams when treating patients who are seriously ill or at risk of deterioration. Imagine, so it was started in UK, in States, now UK, it comes to East, then we have used it here also in Saudi Arabia. The main purpose of this SPAR is to alleviate communication problem that rest from the differences in communication style between healthcare professionals. Because I specify SBAR, in each part of it, there is something to write it. SPAR was later adopted by many healthcare, and it is among the most popular handover mnemonic system in use nowadays in the healthcare setting. Look at this sheet. It is one of the sheets that the nurse is using when she relayed emergency things to the doctor. You see, it is in details, everything written here, and situation, what you will write. In background, I will show you also this slide. It is beautiful, I feel, and it is old. I got it from the site. There is SBAR. In each, what are the common things you have to do it? In situation, name, age, diagnosis, physician chief complaints, background, allergy history, story, medical and surgical history. In assessment, medication, vital signs, lab, parameters will be mentioned there, and recommendation will be plan, updates, what to do, what not to do, and consult. In letter S, in situation, you will identify yourself and your unit when you communicate, because you will endorse some urgent thing to the doctor. Briefly describe the current situation of the patient and give clear, succinct overview of patient issues. And here you will write the name, age, diagnosis, physician, and chief complaint of the patient. Excuse me, I will skip this one and I will show you the example. This is one of the examples. Mr. Jones is out of breath. Now the nurse is communicating with the doctor. She will tell him that Mr. Jones, let's say Mr. Abdullah here or Mr. Hamad, is out of breath. The staff need to state the following. The reason I'm calling you Dr. X, that Mr. Hamad, medical record number 123456, is complaining of shortness of breath, and it is, as he stated to me, and he has never encountered it before. This is the situation. See, she explained what is the finding. Let's go to the background. That Mr. Hamad, he's 50 years old, man who had abdominal surgery yesterday. He has no history of cardiac or lung disease. So she will write this one in this background. An assessment, where is it? In her assessment, she will say that I have noticed that his breath sound are decreased. Here, as what you notice, she's talking about parameters. I have noticed that his breath sounds are decreased on right side. Respiratory rate reached to 10 breaths per minute. He's having pain, 5 out of 10. And I'm wondering if he has developed, let's say, pulmonary embolism. So this one in the assessment. Now in the recommendation, she will tell him, this is the point of the weakness that the nurse will feel intimidated here, where in fact we encourage them to speak up and to voice up their concern when they communicate with doctors in order to save the life of the patient. She will tell him, I think, doctor, you need to come and see this patient right now. In our culture, unfortunately, the doctor, he will tell her, who are you to let me come? But the patient safety let you come and force you to come. So this means that I will not wait. We have policy in our hospital where I work again, that if the doctor doesn't come, you will call the consultant at home. So when we implemented this strategy, no doctor will say that I will not come unless he's in sterile or he's field or he's doing procedure. Then he will say that I will come in 10 minutes, 5 minutes, like that. So this one, I told you from the beginning, there is SBAR R, and there is SBARC, and there is SBAR. And here, let's talk about SBAR R. R, the response, what there will be, the doctor will come and he will do further assessment and interventions. So here, if the process done in this way, as what I explained, I think we will have it effective communication as what we started initially. So the effective use of this tool will be enhance the family and patient's outcome. It will be more effective when giving reports outside patient's room. This one outside patient's room, if there are 2 patients at the same place. Standardizes information to be given and lessons on communication variability, making report concise, objective, and relevant. Of course, we can measure the compliance of this one. Allow patient to gain exact knowledge of information related to his care plan. Why? We go back to the patient/family engagement. Improve the relationship between caregivers, and it will increase the overall health of patient. Oh, there is limitations. Is there, do you think, any limitations? Of course. Like any tool we use in the work, it will not be that much easy to use it by each and every one. I remembered when we started using a SPART tool, a lot of resistance from doctors, nurses, why I have to do it, I will not do it, why this, change is painful. Not each and everyone will accept changes easily. So at least you have to prepare them how to accept the changes. What is the benefit? Because when we have culture of safety, no blame culture, when we have common understanding of safety, I think any changes will be easy to be done if the management and leaders will support and the workers will comply with it. So the limitations here, unfamiliar with the concept, difficult to learn, but supportive environment, role play, and skills assessment may help. Of course, we have worked on this one. Further emphasis on recommendations, since giving advice to physician is intimidating the nurses. Of course, we have worked on this one, and we have decided to call the consultant whenever the physician will not respond. Discussing sensitive topics or information in front of patient and family. Some patients, they refuse this one, and they will tell you, please talk outside about my condition. So we do respect this one. We don't force to talk in front of him. Sharing confidential information with patients, especially if there are two patients in one room. And thanks God now, most of hospitals now in the private, they are having one patient at a time in the room. So no patient, two patients will be together. I will try just to pass by the critical values, which is the other part of my lecture. We have critical values here, like diagnostic test, lab, radiology, nuclear medicine exams, ultrasound, MRI, cardiac diagnostics. All of these things consist of critical values. Imagine there is aneurysm. This aneurysm could be ruptured at any time. If I don't report it to the doctor, we might lose our patient. We are having also bedside diagnostic tests like point of care, like insulin, TSB, bleeding time, portable radiographs, like the one done in the units, bedside ultrasound or transesophageal echo. Also, it is one of the bedside point of care or diagnostic tests. How we communicate critical values, identify who shall receive that one. You have to have policy for that. You have to have also who received that result and when provider is not present, what we will do. Define what results require timely and reliable communication. It should be common understanding in the policy that each and every one knows what to report and when to report and to whom. Imagine an emergency, if any patient having critical value and the result came after the patient left the hospital, the physician who requested that test, he should call the patient to come back to the hospital due to the importance of this critical value. Identify which test or when test results should be actively reported to the provider and establish specific time frames for this process. I cannot relay that blood sugar is 1 millimole. I cannot delay it for 30 minutes. Patient will develop hypoglycemic shock and he might die. How to identify, how to notify responsible providers? By phone, by pager, by paging system, by what? Establish shared policy to uniform the practice in your hospital. Design reliability into the system by creating tracking or making physicians' pagers number available. Some hospitals, they connected the lab result with the requesting doctor. So as soon the result will be ready, entered in the system, the doctor will receive message about that patient, that your patient XYZ, his blood sugar like that, his hemoglobin is 4, 5, and he will act accordingly. Support and maintain systems by partnering with patients and their families in communication about test results. Nothing about me without me. I mentioned this one earlier. So patient is the target for us. So we have to have a system there in the hospital that will ensure the implementation of these reporting. Support infrastructure development by adopting advanced communication technologies, improving lab and other system capabilities, so that you might develop mobile reporting that anyone can receive the result at any time. Even the nurse can be included in that one. The last part here in this lecture today, it is about verbal and telephone order. I will talk here about don't use it unless in emergency. Verbal and telephone order should be documented before the doctor leaves the hospital. Many hospitals, they specify time, 24 hours or shift to do it. When you receive verbal order, we should write down the complete order or test result. The nurse who received or the doctor who received, he will write down. Then he will read back the order or the test result, and the sender will confirm that written statement, and he will read it back in order to ensure that it was relayed to the receiver correctly. So my take-home message to each and everyone, even to myself, effective communication which is timely, accurate, complete, unambiguous, and understood by the recipient reduces errors and will result to improve the patient safety. And even effective communication does not just happen. It takes practice and practice and practice. And hopefully, I'm not saying I'm ideal. Hopefully, I'm also advising myself that any failure in communication, we have to study the basic side of the care provider. If he's not communicating properly, I think he's not safe to stay and maintain safety of the patient. And I hope that my lecture was informative to each and everyone. I'm sorry I took around 1 hour 45 minutes. Forgive me, guys, and I'm ready for any question if anyone wants to ask me.
شكرا جزيلا استاذ مجاهد على المحاضره القيمه ديت والانفورماتيف ليكتشر زي ما انت بتقول، وباذن الله مؤكد انت ضفت لنا حاجات كتيره يعني وحاجات مور براكتس بالنسبه لنا، ونفتح الاسئله. لو في اي حد عايز يوجه اي سؤال استاذ مجاهد اتفضل يفتح المايك على طول ويتكلم. اوكي يا جماعه اتفضلوا. في اي سؤال يا جماعه؟
هسألكم إذا ما في أسئلة.
مفيش اي حد عايز يواجه اي سؤال؟
ايوه
تقريبا كانت اتفضلي يا حضرتك.
انا بس حابه اشكر حضرتك بصراحه، حاجات يعني معلومات مفيده جدا، والف الف شكر لحضرتك والمجهود ده.
العفو يا أختي، حياك الله.
ماشي شكرا.
مفيش حاجه غير الشكر يعني؟ مفيش اي اسئله؟ طب اوكي، هننهي باذن الله. شكرا جزيلا مره ثانيه للاستاذ مجاهد على وقت اللي اداهولنا والمعلومات القيمه اللي اداها.
العفو دكتور.
وباذن الله كده دايما تبقى على طول، يعني دايما تظهر معانا في اي ايفنت احنا بنعمله ونستمتع لخبرتك الواسعه في المساله دي. وقبل ما ننهي بفكركم بكره باذن الله ميعادنا مع الدي 4 مع الدكتوره منار، في منار جبر طبعا في الليكتشرز هتكون باسم لين هوسبيتالز. فباذن الله كده مستنيينكم في نفس الميعاد الساعه 7. ماشي، ولو في اي حاجه تواصلوا معايا على طول على الواتساب، لو في اي مشكله في اي شيء نحاول نحلها مع بعض. شكرا جزيلا لحضوركم، واتمنى ان احنا نكون بنقدم اي شيء مفيد بالنسبه لكم. وطبعا انتوا في الاساس انتوا الاساس عندنا، وبرضه بنبهكم ما تنسوش الفيدباك بتاع الاكشرير مهم جدا لنا من ناحيه الامبروفمنت، ان احنا نحاول دايما نطور نفسنا ونكون عند حسن الظن باذن الله. شكرا جزيلا لكم وتصبحوا على خير.